Almost from the onset of the coronavirus epidemic in the United States, New York has been described as the epicenter of the outbreak, and Elmhurst Hospital in Queens, the epicenter of the epicenter.
Obviously, Elmhurst Hospital in Queens is right now the epicenter within the epicenter.
Elmhurst Hospital is the epicenter of the epicenter.
And Elmhurst Hospital is really at the center of this crisis here in the city and in the country, with doctors desperately trying to keep up with the growing number of patients as supplies dwindle.
And you see the black body bags? You say, what's in there? It's Elmhurst Hospital? Must be supplies. It's not supplies, it's people.
Also from the beginning of the crisis, ventilators were described as essential life-saving equipment, initially in short supply.
You picked the 26,000 people who are going to die because you only sent 400 ventilators.
I knew that every person who needed a ventilator and didn't get one would die.
But why does New York, and Elmhurst in particular, appear to have been hit so much harder than other places in the United States? And were ventilators ever the right approach to treating COVID-19, especially once we realized that 60 to 90% of those vented do not survive? The experience and observations of nurse Erън Olszewski seem to offer some answers to these pressing questions, while simultaneously providing frontline information about a number of other hot-button topics, including the disproportionate number of COVID deaths among Americans of color, the distortions surrounding do not resuscitate orders, the disregard for personal protective equipment standards, and the clustering of COVID positive with COVID negative patients, which she witnessed again and again, and the tremendous amount of nosocomial or hospital-acquired infections that resulted. Perhaps most urgently of all, she speaks of the therapies and protocols employed in her home state that did work. Erъn was brought from Florida by a service funded by the Federal Emergency Management Agency. She spent almost a month at Elmhurst. What she saw there compelled her to become a reporter and whistleblower alongside her already extensive nursing duties. She made recordings, posted warnings on social media, and spoke through proxies about the nightmare conditions she witnessed. Erъn was raised in Wisconsin and enlisted in the Army when she was 17, just before 9/11. She deployed in support of Operation Iraqi Freedom in 2003. Part of her duties involved overseeing aid disbursement and improvements to hospital facilities. While in country, she received the Army Commendation Medal for meritorious service and was wounded in combat. Erъn eventually retired as a sergeant and became a civilian nurse in 2012. A mutual friend who was helping her make hidden camera recordings introduced us to Erъn. After working a long shift at the hospital, she agreed to do an impromptu interview in her room at the Marriott Marquis overlooking Times Square. We encourage the viewer to leave aside their preconceptions about the nature of what is happening, to hear firsthand from an eyewitness who at great personal expense and without political prejudice of any kind now openly reports what she discovered in the hopes that the information will be put to good use to save lives. She began by telling us one of her most disturbing findings, that people who had repeatedly tested negative for COVID were being described as COVID confirmed.
Okay, so if you look close, I'm in my patient's chart. I am pulling up like their laboratory results. So if you look here, you'll see COVID-19 bioreference lab. Here are the test results. As you can see, 5/1/2020 at 17:16, not detected. They test for a second time, 5/4/2020 at 17:59, not detected. So both of those are negative. Scroll up to the top. This is my patient. They are on a vent and they are being called COVID-19 confirmed. Droplet in contact and eye protection.
So this person is droplet and eye COVID confirmed. Positive A, click, not detected. No resulting lab available. Oh, pretty good.
while Erъn was using her hidden camera to document another chart showing a patient with negative test results who nonetheless was labeled COVID confirmed, another travel nurse entered the room. They began to discuss what Erъn was seeing.
If it says bioreference,
that's
that means
here.
It's done here.
So not detected here, but
So
it's presumptive. Now, they're all...
But they are detected. They're saying it's positive. Not detected.
But it's not
What does
detected.
that say? What does that mean?
So I
You
was...
said that they were vented immediately upon being brought in, is that?
Yeah, so the thing is they're coming in with difficulty breathing, and a lot of these patients are really coming in with anxiety because they're scared. And when I was back home, I was working in the ED out in the tents, and most people that were coming through with like symptoms of just, anxiety, or they're worried and they're breathing fast, and then they get all nervous. So this is how the people are like coming in. Now, I'm not saying that some of them don't have COVID. Like there are people that come in and they really do need help, not to the extent of a vent, but they need help. But these other people, like this person who wasn't COVID multiple times, and a lot of them are on either Medicaid or Medicare. They're poor. They're from, a lower class. We're at a public hospital. They need the funding. So take them. They take them. And they tell them pretty much that if they don't get on a vent, then they're probably not going to survive. But the reality is, if they get on that vent, the likelihood of them walking out the hospital is slim to none.
And can I ask you, what PEEP are they on, and is that being mandated or specified what the pressure is on the vent?
Here's the thing with this. So you don't have actual doctors that know critical care, ICU doctors on these floors. There's a dentist, and there are residents with these. So residents are essentially students, and they have no idea what they're doing. Like I had to police a resident because he wrote an order for me to run Versed, which is a medicine that you have to be very careful with because it can kill someone, at like quadruple the speed of what you should be running it at the dose. And had I not known that, then I would have easily killed the patient, and it would have been okay under their COVID standards. So everything is kind of a wash. Nobody's held accountable for anything, and these people that are at events are essentially being like, these residents are like practicing their skills on them. So they're practicing central lines, they're practicing like invasive procedures that are really unnecessary.
What is the percentage of Black, Latino, white? What's the racial composition?
Hispanic and Black for the majority.
And what's the age
And
range?
Asian.
And Asian. And what's the age range?
20-year-olds all the way up to 70, 80-year-olds. Very few 80-year-olds, but the majority of people, I would say, are in their 40s or 50s.
Wow. And what percentage of the people that are in there would you say actually have tested positive for COVID?
Half. Probably half.
But everyone is being treated as though...
The entire hospital is COVID. So half the hospital is not COVID, but they're on COVID floors.
So let me just ask you about nosocomial infection. So you're saying they're putting non-COVID or COVID rule out with definite COVID patients?
Yes.
So I was only wondering, because I was looking at all the patient rooms, and this patient is in with a non-COVID. I don't understand why they're doing that.
I know. There's 4 patients in a row here
Yeah.
on COVID. And this is supposed to be the COVID place.
Yeah.
Because 7th floor, they've shut it down.
That's
and
right.
cleaned it.
I'm confused.
And then they're going to have non-COVIDs there.
Yeah.
This is going to be the only COVID, so they shouldn't put any non-COVIDs here.
Well, that's what they've been doing.
They're banking on the fact that they'll get it because they're already immunocompromised. So and they'll put them in the same room. So there's double rooms. So you have a COVID with a non-COVID. They don't even care. We have enough rooms where they can be separated now because it's not as busy as it was, 4 weeks ago. But they don't care. They're just putting them together. I have that right now happening.
And like the guy over in...
I had 2 26 that were 2 negatives.
And they end up positive. Like the guy over in 29, I had him upstairs because I was on CCU before it.
Yeah.
And he came in with a stroke.
I know, that's what 26-1 was, a stroke.
And no COVID. And now he's got COVID and he's on a vent.
Well, because we gave it to him here.
I don't know how this ended up being COVID Central.
I know, but she literally came in with a broom. And then she left like 5 minutes later. My patient had died of COVID, and she didn't mop the floor. She was cleaning, getting prepared for my next patient, and she didn't mop the floor. I was like, that's
a standard.
I didn't think I had to tell her that.
Right. People don't know how to properly wear their PPE. Let's go back to Ebola. Like when Ebola was here, people took that very seriously. You have a nurse in the room in all the head to toe PPE. This is Ebola. This is I'm going to compare it. And you have another nurse that's outside the room handing supplies. You know, the clean nurse and the dirty nurse, right? Going, and when they're taking their outfit off, one nurse is unzipping the back so she can take it out, walking out. They're not doing that here. We're wearing like our scrubs, and then we have maybe like a net top. Our pants are exposed. They're wearing booties over their shoes, but the booties are going room to room to room, and then people will wear them through the hospital.
So there's massive spread just through the improper use of the PPE.
I mean, it's a no-brainer. Everyone, it looks good. It looks good. It looks like you're super safe, but in reality, it's ridiculous. So you'll go room to room. You'll maybe take that top off, put a new top on, but the rest of you is still exposed.
But I mean, why are they doing this?
I know. Suspected, and then there's like principal hospital. Does that mean like a nosocomial? Is that what that means?
Like we have in the United States, and we've had it for a while, a rapid test. It's 45 minutes. Do you have COVID? Don't you? They're not doing the rapid test here.
They're not?
No.
Okay. At Elmhurst, you've never seen them?
Nope, they don't do it. It's too expensive. They do 5-day. It's like 5 to 7 day turnaround. In the meantime, they admit them onto COVID units. So non-COVIDs, the rule-outs are going to COVID units and waiting for the results. Even though we have a rapid result, which is 45 minutes, and they're not doing it. No, not one.
But would you say it's too expensive? I mean, isn't this all getting charged to the fund anyway? I mean, why not do it? Why not? I mean, are you saying that?
I don't know why. It doesn't make any sense to me. I asked that doctor about it.
How come you guys don't do the rapid test here?
Because city place, I mean, it exists. It's just they don't have access to it. There's only limited supply, so if you have deep pockets, you get it first.
Oh, so money.
Most times it's money about everything, yes.
That's sad.
It's reality.
I compare this hospital to a third world country. I've been in a third world country hospital in Iraq. The Iraq hospital is better than this one, and that says a lot. I've been there. I've been in both hospitals, and this is in the United States, and this hospital is treating low income, mostly people, and it almost makes me feel like they think these people are disposable, and they're not. They're people. You know, people are not disposable. You know, especially the ones that are struggling day in and day out, the hard workers. You know, like trying to reach that American dream, and they're not given a chance because they're brought to this place where nobody cares.
And is there an understood financial incentive to diagnose COVID?
Yeah, of course. So in the hospital that I'm in right now, it's all COVID at this point. Every single floor is COVID, and they need it that way, obviously, for a reason, in my opinion. But a person cannot come to the floor unless they have a COVID diagnosis.
Is the reason, did they not want to cross-contaminate? Would that be the legitimate reason why you would create an all-COVID floor?
Here's why I will say no to that, is because they're admitting people for, quote, COVID rule out. So this guy was probably admitted COVID rule out, tested him, they saw that it came back negative. They probably already did something where they needed to now call him COVID, in the hopes that if they're putting him on a COVID floor and there's nurses going room to room to room, he will get it, and then they'll be backed when he does pass that he did have COVID.
Yeah, I mean that's quite a charge. I mean, what makes you think they really want them to get COVID? Because
money. Money. I think it's at least $29,000 per patient, and then you have to think you are also charging supplies and more supplies and more supplies. That's just like a bonus money.
But but the residents aren't getting that, right? I mean, why?
Oh, that's the thing. And I actually I've went at it with a lot of residents already, and they're order followers. So there was a resident, and I have this on tape. I taped it because it was just so disgusting to me. A 37-year-old, which is my age, was not a DNR. He was a full code. His family in depth discussed with the doctors that they want us to do everything they can to save him. He came in talking. He was very terrified. He was just like, totally alert, knew what was going on, and they convinced him to be on a vent. Now he's dead. But the doctor said when I got into shift that if he codes that we are not to resuscitate or try to save him. And we flipped.
This is important. I did ask them if we can put a DNR order, and they said no. That's up to the attending.
Okay, so we're going to code him.
That's what I said, and they said no, we're not. I said yes, we are. Yeah. We're obligated to. So then
you got to say something though, like it's our license. Unfortunately, you guys got to put in an order. Just something.
That's what I said. Yeah. I said I'm obligated.
Yeah.
What did she say?
So that she's like, the higher up said. I said I don't care what they said.
What higher up? God? We don't have a God here making decisions.
I said I don't care what they said.
So we're supposed to. He's not DNR, but we're treating it as DNR.
Basically.
Does his family know?
His family knows the situation. I think they called them and they told them. They were trying to do a school attending consent for DNR.
Okay.
All day he spent like in the 80s saturating. It was this one on the forehead didn't work. It was this one worked, and it came back. When I changed it, I was like, oh shoot, it's 90.
Yeah.
So they started playing around with the
Oh shoot, it's 90.
He's still on pressure.
He changed the pulse ox
You put him on AC
from his head to his finger, and he's like, oh, it's 90.
I had to put a sign up last week. Don't touch my.
He's fine.
Nothing.
So.
Yeah.
So what was that?
So that was, we were just getting on shift because we're starting the night shift at 7. And that was the nurse from the day shift saying pretty much we shouldn't code him if he's going to code. And then I turned my glasses on.
Why are we being told not to code him, essentially? That's what he said. I mean, because I'm going to tell you right now, if he bottoms out, I'm jumping on his chest. Period. Point blank. It's going to happen.
Okay.
Because until that status is changed in the computer, that's what I'm obligated to do under my nursing license.
Right. I mean,
because you guys aren't going to back me up and protect me.
Well, Elmhurst does have a policy given, like a COVID policy, given the scarcity of dialysis and blood.
It can be a chem code, it can be whatever.
That it's not, there's not it's a difference. Normally the standard is whatever the family says, like we just do. So if they would say code him for 5 years, like we just do that until they die. It's a little bit different now because of the new policy in place with Dr. put in place, which is that you don't need full family like you can just tell someone that it's medically futile and that we're not willing to just pour blood and resources into something that would be impossible to get back.
Right.
But look, he's 37. I mean, it's brutal.
Well, so they tried. Well, our higher ups have agreed, and our attendings agree that this is futile care at this point. He's not going to make it. I said he doesn't have an epi drip going. He doesn't have anything to sustain going. And I said, and who decided this? And I said, can you put a comfort care order in then? No, we can't do that. Can you put a DNR order in? No, we can't do that. I said, so what's our plan?
Do we have to modify?
She goes, well, he's dying. And I'm like, I understand that, but there needs to be an order indicating that either I'm doing compressions or I'm not doing compressions.
Well, I can say that we can all be in agreement that we will do it. I will definitely.
Because I'm going to jump on him.
Yeah. So will I. I'll go right with you. I don't care. That's what we're here for. I'm not playing like these
until
stupid
they
games.
change his status that he is a DNR, and they can do it to physician consent if they've talked to the family.
Yeah.
But until they change it, and I see it, he's a full code to me.
We know when someone we're close. We'll pull the code card up and be ready. You know, we're ready. I had the epi ready. That's one of the first things we do. And she wouldn't let me give it. So this was that woman, and the entire time, and this was over his body, his alive body, and we're arguing, and she's laughing. She was smirking, and how this man died was the nurses arguing with the doctors over him as he was dying, and she's smirking the entire time. It was probably one of the worst experiences in my entire life. But all I can think about is that at least he knows that we were fighting for him when he died. You know. But this was my conversation after what happened, and the guy I told you about earlier that had pulled his tube out, he was up at that point. Like, he was on the same floor. He had pulled he was the one that they wanted to sedate. So at that point, he was doing better where he could walk. This doctor had put a diaper on him and told him to poop in his pants. So after the code, I went to go check on him, and he goes, I have poop in my pants. I'm like, why do you have poop in your pants? And he said that because the doctor told him that he has to do that, and I just lost it. It was her.
This is wrong. It is straight up it is wrong. And I am 37 years old. I have been in a hospital since I've been 16. Military hospitals that well.
What aspect of it was wrong to you? I agree that there were parts of it that were wrong too. So.
Calling a patient a DNR when there's no order for it, and telling us, like straight up telling us, you're not doing anything. That's wrong. If that was my brother or my father or anybody, I would be furious. And I guarantee you, if I called his family right now and told them what happened, they would be furious too.
I flipped. We were all crying. There's a lot of nurses that know that this is wrong, but they're afraid to like say anything publicly.
She said, when I was talking to her, she said, we're not always given the orders. It comes from the top down. And I was thinking, that's the exact problem with everything. Where's it coming from? What's the purpose? Are you guys really trying to kill everybody like everybody thinks?
Within our unit, it was a big fight, and ultimately the kid died with us over his body arguing about this.
It goes over there.
Yeah.
And the doctor will just write it up that we
Yeah, I don't trust him though, because I don't know him.
I'm sorry, I'm not doing that.
There's a doctor that came upstairs that I had worked with prior. He was working in the ED, heard what happened. He came into the room with me and told me that what I did was good. And that, so there are good doctors in here. I guess the word traveled after this.
You mentioned earlier that this is a common occurrence where people come in able to speak and they just have low oxygen levels and they're put on a vent. So what's going on there?
I don't know. I honestly have no idea how. They're assuming everybody is just the same. There's no individuality anymore. These residents I think a lot of them are just stone cold. You know, there's no emotion, and they don't view people as people anymore. And it's really sad. Like I came a little bit later, you know, after the big rush, but there was still a lot of people coming in, and a lot of us were just in shock. Within the first couple days, you could see exactly what was going on.
My bigger problem with this whole scenario is when they intubate people who don't need it.
Yeah.
And it looks very clear to me that they're just pushing it.
You almost feel like you are literally living in the Twilight Zone. And you feel like you're the only sane one in a bunch of insane people. And it's scary because these are the people that others are trusting to take care of them. And they're really doing the opposite. I'm to the point where I'm afraid that I'm going to start thinking that this is normal. I don't want to ever get to that point because they think that. Like the people I work with that are local nurses and doctors don't see anything wrong with this.
Really? I mean, they don't.
No.
Do they see? Was it just like kind of a hard past few months? Is it or?
This has been like this, and from what I hear, like from, I mean, there are good nurses that work there too. Like I have made good friends with a lot of the nurses that do work there. There's good people, but they're outnumbered.
So what happens? People come in like this 37-year-old, and what was he complaining of, or what was going on?
Respiratory distress. He didn't have COVID either. He did not have COVID.
And how do we know that?
I took care of him. I have the same type of results from his chart as I do my other patient.
It was like the day before intubation, he was fine on the rebreather.
And then they intubated, and then he got a pneumo, and then they put in a PEP tube, and then it's finished.
And now he's 37 years old and dead.
Because that's what I'm seeing, like all these negative tests, and they're putting them on these vents. Hopeful that they'll get it. They're being put on these COVID floors. It's murder. It straight up is. It is setting these people up for failure based on money.
But Medicaid is who pays out, or who's paying this bonus of $29,000?
I believe it's Medicaid, Medicare. It's government money, but I don't know exactly where it's coming from. But I know that it is. But I know the orders are coming from the above, someone above, and everybody says that it's someone higher up. I'm like, good, call them. Like during that DNR when they're telling us, or the full code when they're telling us not to, do CPR. I'm like, all right, call your higher ups then. Let's talk about, and they wouldn't, because they're all scared. Everybody's scared. And everybody's scared to stick up for themselves. And I've called a lot of doctors unethical to their face, and they deserve it.
I'm a nurse. I'm an advocate for my patients. And
to the flip side of it, but I totally agree.
But no. Just wait.
If there's a DNR.
You were laughing and you thought it was funny. You were like smirking. You're being really rude to all of us. And I thought that was really.
I'm not being rude in that.
It was really, yeah, you are. It was very disrespectful. Okay. And I don't think that you're going to be a very good doctor.
Okay, I understand. Thank you.
You're welcome. I hope you learned something from this.
Was this the dentist, or was this, or these are residents you're talking to?
This one was a fellow. She was a CCU fellow. Cardiac. She's a cardiac fellow.
What killed him? Did the vent kill him?
Yeah. Oh, yes. They're so sedated. He had probably 8 or 9 drips. It's all sedation. It's all sedation and paralytics. So you are asleep. It is essentially like you're under, you're in surgery, when they put you under like that for a good month straight. There's no way you can recover from something like that. You'll be brain dead if you do.
So can you list some of the drugs that they're put on the drips?
Yeah, there's propofol, fentanyl, Nimbex, Versed. Gosh, hang on, I have a list. I think it lists from. This is one of my patients was on this. Just one patient. So Nimbex 100 milligrams, Precedex 400 milligrams, fentanyl 2,500 micrograms, heparin 25,000 units, Versed 50 milligrams, Levophed 16,000, Neo 50 milligrams, Propofol 10 milligrams, Vasopressin 100 units. This is one person, and all these drips are running at the same time into them.
So, in the case of this 37-year-old, he comes in complaining of some respiratory distress. Did he have low blood oxygen?
Totally healthy guy, and he was satting that's the oxygen saturations, and 88, 89.
So a little low.
I mean, yeah, but people do that. You and I probably do that. We're not monitoring our oxygen, all day long.
But he felt shortness of breath, so he came in.
Yes.
And what was the next step? What would have happened next?
He went to a step-down unit, among other.
What does that
COVID.
mean? Sorry.
It's just a unit where people aren't quite on the vent yet, and I say on the vent yet because I should call it a step-up unit to the vent. But
so was he? What's the phrase you used?
COVID rule out.
COVID rule out.
So that's how they admit everyone to the floor that doesn't have a positive COVID immediately.
Okay, so he's put in the step-down unit, which is a euphemism for step-up unit.
Yeah.
And what happens to him there? What's going on there?
Oxygen. I wasn't in this unit. My friend was.
So just normal oxygen, nasal?
No, they'll do a high pressure.
So what does that mean exactly? What does it look like?
Pretty much like a forced. It almost looks like a big thick nasal cannula, and you put it in your nose, and it forces the pressure in. It can almost be it's still causing your lungs to expand, right? But what they really need to be doing is the non-rebreather mask, but they just skip it usually. They go right to the high pressure, so their lungs are already,
So, and tell us what a non-rebreather mask is.
So that's just, there's a bag that is on the end of these masks. It's not forcing air down your lungs.
Okay.
It's more natural.
Okay.
And you can put 100% oxygen. That's what people need.
Okay, so and that really is not the protocol. It's not the protocol to start people on that.
I mean, it should be, but it's not how they're doing it now.
I mean, in your prior experience dealing with people with low saturation, would that be what you would do?
Oh yeah, that's what we were doing, in my hometown.
And were you having better outcomes there?
Yeah, we didn't have this because we treated them properly,
What would you say the case fatality rate was?
None. 0. Yeah, by me, 0.
And what is the likelihood of coming out of the hospital you're in?
I'll tell you that the unit that I've been on, the only person that survived, ironically, is a guy who pulled his own tube out. Yeah.
So he woke up enough to be able to do that?
Yeah. He wanted it out. He should have never been on in the first place. That's a whole nother story.
So let's just keep going with this 37-year-old. So he's on the step-down unit, and he's being given semi-pressurized oxygen. It's not a rebreather mask. And then what happens to him?
They'll start treating them with medications, that will...
And are they checking his saturation at this all the time? Does he have...
Yeah, he's on a continuous pulse ox, but the minute that he desats, they'll see oh no, he's at 87 now, or oh look at this, oh he's gonna need more help, and then they go tell them that they need more help even if they don't. It's ultimately what it comes down to is people being just lazy and wanting to treat. They just want to treat.
Is there any incentive to you're saying that the incentive for the residents is kind of experimental almost.
They're order followers.
And they're
they want to please. That's what they're doing. They want to please. And the protocol of that hospital is to treat.
To treat invasively according to this protocol. And do we know where this protocol originates? I mean, because obviously the governor was talking about getting vents. Everyone was talking about getting vents. So this seems like this comes from very high up.
Yeah, I mean, if you're gonna tell somebody, the entire world essentially, especially the entire United States, when they're like, we need the vents, like, if you tell people something enough, they're going to start believing it. So that's exactly what happened.
Tell me why Cuomo immediately thought 2 months ago that they'd need 30,000 beds. How do you just come up with a number?
Cuomo's an idiot too.
Well, Medicare's paying them more money for people.
29,000 of that.
So our 37-year-old, what happens to him next? So they say, okay, it looks like he's at 87, he needs more, and so is that the point at which they would intubate him?
Yeah, that's when he that's when he stepped up. So he stepped up to the ICU.
He steps up to the ICU.
For more care, right? They start off with a little bit of like muscle relaxer, and he's woozy. You have to remember there's no family with these patients, so they're alone and in hospital by themselves during a pandemic that they're terrified of already. That's likely what brought him in the first place. He's totally healthy otherwise. And then you have doctors. They think they're doctors, but they're resident. Technically, they're doctors with absolutely zero experience. I've had to teach residents several nursing skills, telling them that they have a choice, they could likely die from this, or they can be saved by, getting a tube, and that will help them breathe. They don't call it ventilator. We can give you a little help breathing, and that's it. Then they get the sedation, and they go to sleep. And that's it. They don't wake up. He's in a body bag.
And so the drugs have a deleterious effect on the body, on the brain, but is there something about the pressurization of the lungs that is also causing harm?
Yeah, they're having the PEEP, that's the pressure in his lungs, which is causing the barotrauma of people. It's blowing people's lungs out. So when that happens, what do you got to do? Turn it up more. You just keep. Because the membrane expands, so that you need, in order to fill them and deflate them, you need more pressure. Yeah, you're gonna have to max it. I mean, we have a guy right now who's maxed out on everything. There's nothing more you can do. So then what? You just wait for them to die? I mean, there's nothing you can do. Can you tell us what PEEP levels are they started on? It depends. They're always usually, they'll start, there's some good ones. I can't say everybody's bad. Mm-hmm. There are some good doctors that'll start them out on 5, which people should be at about 5. But that doctor goes home, and the next doctor comes on shift and cranks it up. Then what? It's hard to go back down. And what oxygen level are they put on? It depends. I mean, as they start to deteriorate more and more, then the oxygen obviously is going up. There's a guy right now, I have him on 100%, and I'll have to come in and, give him a little bit more rush of 2 minutes of even more oxygen just to keep his stats up. I mean, that's what happens to people. In your home state where you were treating people, what would the protocol be? I mean, it varied upon each individual, but we definitely would never go immediately to, you're going to need a vent. You didn't feel pressure to diagnose people? There wasn't a pressure to diagnose people COVID? Not at all. No. We're not a public hospital, too. That makes a huge difference. What I'm seeing is it's the public hospitals, and this is like in other states, too. If you look at all the hospitals, most of them are public that are needing money. But our hospital would just treat them based on the individuals, and they were using the hydroxychloroquine and the zinc and, that protocol, for sure. At your hospital? Oh, yeah. And that seemed to work? Yeah. We didn't have anybody that died. I think there was one patient that was admitted and went home like the day later. And I'm in a pretty big city, so. And were these people with
who were elderly with comorbidities who were having good outcomes?
Yeah, actually one guy the one guy that was admitted came from a nursing home. And he was obese, like severely obese.
And he
yeah,
left.
He's fine.
He left after a day.
I think it was like a night, maybe 2 nights max, but.
And what do you remember what he was treated with?
I didn't have him on the floor, but I can imagine he was treated with the protocol that we would prescribe the patients before they left the emergency room.
Which was?
The hydroxychloroquine, zinc.
Why do you think that's been demonized so much?
Because it's working, and then people wouldn't need vents. I don't know.
Only on 2 tonight, a Houston hospital is having success treating the coronavirus patients. In fact, its recovery rate is perfect.
Fascinating, isn't it?
To treat patients here, Dr. Veron is using an experimental drug protocol. It's a cocktail of vitamins, steroids, and blood thinners. Each patient also is getting hydroxychloroquine, the malaria drug touted by President Trump. The protocol is controversial because there hasn't been time for extensive testing, but Dr. Veron says it works.
We've treated over 40 plus patients with this treatment, and we haven't had a single complication.
So far, he says, none of his patients have died.
This is time of war. There is no time to double-blind anything. This is working. And if it's working, I'm going to keep on doing it.
What we're finding clinically with our patients is that it really only works in conjunction with zinc. So the hydroxychloroquine opens the zinc channel, zinc goes into the cell, it then blocks the replication of the cellular machinery.
You're prescribing it, and it is working for COVID-19 patients.
Every patient I've prescribed it to has been very, very ill, and within 8 to 12 hours, they were basically symptom-free. And so clinically, I am seeing a resolution that mirrors what we saw in the French study and some of the other studies worldwide. But what I am seeing is that people are taking it alone by itself. It's not having efficacy.
Okay.
What can you tell us about any confirmed COVID cases that you've seen? Both in your home state and here in New York, what have you noticed about them, and what do their stats look like?
Okay, so the real confirmed COVIDs that come in, like, you immediately know that they're COVID because they cannot, they can't breathe. They literally can't breathe. So they do need that non-rebreather mask, or their stats will quickly drop to 60s, 70s. You want to be at around 90 to 100.
So they can't talk even.
Some of them can talk. A lot of this is anxiety, but the problem with this is they were being told, the public has been told to self-quarantine, right? Stay home. That's a problem because these people could be getting early treatment.
There's clinical trials emerging that appears to show that it decreases severity early in the game, before you end up hospitalized, before you end up on a ventilator.
And they're not, because they're told to stay home. So now they're getting really, really sick, and they come in on an emergency status. They waited too long. If they didn't wait too long, they're easily treatable.
And easily treatable, you feel, with some of these treatments, like 100%. Zinc and hydroxychloroquine, and
it's working. I mean, it's been proven to work. There's a doctor, I think, in Texas that's using that protocol and a shot in the butt, of antibiotic shot. I don't know exactly which one she was using, and she's successfully treating. And she was saying that the pharmacist now is calling her every time that she prescribes, the hydroxychloroquine, and asking what the diagnosis was of the patients in order to give it to them. I'm like, that's a doctor-patient relationship. So the pharmacist, I guess, was told to do this. And, in New York, the governor said, pretty much put a ban on it. So why? What made him, a medical professional now to make these decisions and intrude on the doctor-patient relationship? Because I know. I've seen it. They want a vent. He wants to be right. They requested all these vents. They want to use them.
As part of the same executive order that granted hospitals near blanket immunity from malpractice litigation during the epidemic, Governor Cuomo singled out hydroxychloroquine as the one drug that could not be used as an off-label therapy for COVID-19, except as a part of approved studies. The order was issued ostensibly to prevent hoarding, so that those who take this decades-old, inexpensive treatment with a long safety record for approved conditions like lupus would have access to it. He later amended the order to allow hydroxychloroquine's use in later-stage patients in hospitals, but not in early outpatient treatment. Both hydroxychloroquine and chloroquine had shown efficacy in the prior SARS coronavirus epidemic, and studies in France and other countries had already shown its effectiveness for COVID-19. But instead of making research and production of a promising therapy a priority so that there wouldn't be shortages, vents became the near-exclusive focus, along with the search for a vaccine. This has been true even of President Trump, who, despite his public cheering for hydroxychloroquine, has not made it the focus of warp speed funding and testing. A number of U.S. studies have shown the promise of hydroxychloroquine-based therapies, most recently a Yale University study focused on early treatment. And in what may be the most scandalous retraction in recent memory, a Lancet paper that purported to show hydroxychloroquine alone or with other therapies was in fact dangerous has been shown to be based on fraudulent data. Errön's home hospital system confirmed in a phone conversation with Perspectives on the pandemic that they have used a protocol involving hydroxychloroquine and zinc to great effect.
Because in your view, this should be an individually decided doctor-patient choice.
Everything should be that. I mean, there is no reason that any government should get in between a doctor-patient relationship. That's none of their business. You know, if anything is HIPAA protected, it should be that. I mean, when you think about it, it's sickening. It's the same reason they won't use like other treatments that are successful around the world. And I had a conversation with a doctor about this.
Are you guys doing like different sorts of like treatments? Because I know like
nothing works.
They have. Yeah, but I mean, there's, you know, they're coming out with different things that are in the testing phase.
It's the same thing they come with a plaquenil that kill more people than actually save. So that's one.
And he said that they don't work anyway. And I told him, well, obviously what you guys have going on here isn't working. So what's the harm in trying?
I don't expect any of these people to survive. 90% of them would die.
I mean, it's just maintaining. So I figured if it's assumed they're gonna die anyway,
just try.
Why not throw a few?
Well, it's, you know, I don't know. That's always an issue in medicine, whether you should just throw things whether they're dying anyway or not.
But if you could find a cure.
Well, there's no cure, so there's no antiviral therapy. The only way to do it is cure, but there's no
treatment, I should say. Rephrase. Treatment.
You could treat it, but you know, you have to have some scientific basis for whether these things are working or not. And just throwing everything at them, you could make them worse. So
worse than death.
Huh?
Worse than death.
Well, we said 90%, maybe that 10%, maybe they're true. I don't know. But I mean, if there's no basis for it working, I mean, you wouldn't just try things just because. I mean,
I would.
I might,
if it could save my life. Yeah, hell yeah.
So, with these actual COVID patients, they present by not really being able to breathe. Maybe they've, as you say, they've probably waited too long. They're not able to breathe, and some of that's anxiety. And what else? So what else do they? How else do they present?
So their lungs, if you look at their x-rays, you can immediately see that these patients are affected by COVID because they're white. Their lungs are white. And the secretions are really, really thick, mucousy, and white. And that's what the photo or the x-ray of these lungs look like.
And so what does a white lung mean? What is that? Is that mucus?
Yeah,
in the lung?
it's coated. It's almost like their lungs are coated.
So that makes it hard to obviously transfer oxygen into the bloodstream. And so they've got very mucousy lungs. And how do you deal with that? Is that what hydroxychloroquine and zinc do? Or?
I mean, those treatments are for beginning stages. Like once you get to the stage where your lungs are looking like that and you're having a lot of trouble breathing, there are proven treatments that have passed like 3 trials in Asia through Dr. Chang. He's a U.S. board certified physician. Is this like extremely high dose IV vitamin C? He's successfully treating people with that, and what that's doing is it's giving your body, essentially your lungs, like the power, the antioxidant power to kick it out, while you can be getting IV antibiotics to be treating this and getting rid of it. But they don't want to have anything to do with it here. What they want to do is just throw them on a vent and sedate them.
Yeah. Have you done the high dose IV vitamin C that's successful in Asia?
That doesn't work. Really, the other stuff does. People are trying all kinds of silly stuff. There is no scientific basis for vitamin C to be working here.
Well, the Dr. Chang, he was the one that it went through that high dose. I'm talking super high dose IV vitamin C. That's super antioxidants. Helps your body fight that.
Yeah.
It passed three trials. And it's being effective. It's just weird how like everybody just like shuts it down immediately.
Because it's the vitamin C story has been around for a very long time.
Oh, that's weird because I take it daily and I haven't been sick.
You may just have good genes if you're not getting sick. I don't think it's from vitamin C. You may just have good genes.
So how quickly if you have a COVID and a COVID rule out or a non-COVID right next to each other on vents, will the COVID patient die more quickly than the non-COVID patient?
If they're on vents, no. They're both the same at that point. Yeah.
Really?
Yeah.
So even though the COVID patient with the, presenting with a very mucousy lung, I mean, are their lungs filled or they're just coated?
I shouldn't say that. I'll take that back. It really depends on the person, how healthy they were before. That really determines how long that they're going to be able to sustain the paralytics and sedation and multiple different just procedures. Even when you're like sleeping or you're like knocked out, sedated, and they're putting you through like these central lines that they're putting in and trachs. They're doing trachs. Even though they're practicing, essentially, your body knows what's going on. It's still going through a trauma. It's very traumatic, even when you're under. That's why surgery, it takes a while to recover from, because you'll feel it for, how long do you feel that if you've ever had a surgery? And so they're putting their bodies, through horrible things, and that's adding more stress. It's killing them. Yeah. So the guy that pulled out his tube is really unique, because I saw him from the minute he got to our unit, and I didn't agree with him coming to the ICU. But he was admitted with hyperglycemia, which is high blood glucose, at like 700. So it's pretty high. I learned later that it was high because they were treating him with a lot of different psych drugs, and that increases it. It was the treatment that got him to the 700. And when you have a blood glucose that high, you're automatically going to have altered mental status. So now they called him crazy. Okay? So he's admitted to the ICU, and everyone's like, well, why is he here? Because he was acting out. He didn't know where he was. He was confused. And I went in there, and he wasn't my patient, but, we help each other. And I went in there and I tried to talk to him and calm him down. Like, hey, he's just like, I just want to get out of here. He has soft restraints on, so they restrain everybody. We have soft restraints on all of our patients, the majority of them, for sure. Which I think is crazy. But it goes with the territory, because everybody's really lazy and it's easier to just treat them with drugs or tie them to their beds. So he was tied up. Obviously, what is that going to do? It's going to make, you're tied up in a hospital, you don't have any family. What do you think? You're going to freak out. So he was. And his oxygen was sitting at, 88, 87. Doctor comes in, I should say, fellow comes in, and she says that if he can't get if she goes, if you can't get your breathing under control, we're going to have to put a tube in you to help you with that. And I go, what? I'm like, he doesn't need a tube down his throat. Like, he doesn't need a vent. She goes, well, yeah, he's desatting. And I said, no, like, absolutely not. He does not need that. We need to get his blood sugar under control and he will be fine, and maybe not tied to this bed. And she goes, yeah, we'll talk about it. We'll just monitor him. And I was working night shift. This was probably around 6 a.m. At 6:45, we had a code down the hall. The code passed. Had to do all that, got out of there. I come back for shift, and guess what? The guy has been on a vent. I was so upset. They did it, I guess the nurses that took over said they did it literally as I left.
So I come back in the morning, he's on a vent. I'm like, you have to be f***ing kidding me. He did not need a vent.
They waited for you to leave.
They did.
We literally, that was the morning we coded 28 for 3 minutes. That we no sooner took the vent out of that room, cleaned it, and put it in here.
Yeah.
And tubed him.
Yeah, they took his vent after he died and put it on him.
So they waited until I left because they know how I feel about this stuff.
Same thing with bed 9. They didn't need to intubate him. He was progressing. I don't think that I don't know what happened after. We tried BiPAP, and then they brought him here, and I thought, well, cross my fingers, we'll see.
And no one survives. He did. He was the only one that I've had.
That's what happened with him.
But he pulled his tube out, and so he has a chance again.
Oh, he did?
He extubated himself.
Oh, he did? I didn't know that. I thought he was extubated.
And how did he wake up?
Turns out that he did drugs.
So he was resistant.
He was
to fentanyl.
All of this stuff that we give normal people didn't cut it for him. So he ended up, yeah. I'm like, you just saved your own life, you know? That's crazy. Don't put that on. Don't put that on. But I mean, it did. You know what's sad? So they pulled it out, and they're like, oh, you know, so-and-so's extubated. I'm like, no way. They don't extubate anybody. I'm like, that's so weird. Here it turns out he extubated himself. And now, he's fine. He's home now. This was just a couple days ago. But, you know what's sad is that he thinks we saved his life. You know what I mean? So he's like, you saved me. And I couldn't, I don't have the heart to be like, no, man, you saved yourself. You have like 9 lives. Because had he not pulled that out, he would definitely be dead. For sure. They don't extubate anyone.
Here's the problem. Not a single patient here, since this thing began, has been discharged or successfully extubated.
I asked the nursing supervisor for a sitter for the guy that pulled his tube out, because when they're waking up, they can be extra, I should say, where they need a little bit of extra attention. And I asked her for a sitter, and she told me that I didn't utilize all my resources first, which was Haldol, all the psych drugs to like chemically, put him to bed.
Your Florida hospital was literally having to furlough people?
Yes. What was happening is, obviously, they shut down all elective procedures. But they were also waiting for the wave. They called it the wave. So we were preparing, and we were in tiers based on our experience. So we were tier 1, tier 2, tier 3, tier 4. And I was tier 1 because I have the, military trauma experience, ICU experience, so on and so forth. So I was working, throughout the hospital, training in other units, cross-training. Ultimately, it was to get hours.
It was what?
It was to get hours.
Yeah.
This is what the hospitals were doing. They're like, okay, we're going to give our employees hours this way to cross-train them for when the wave hits. And then that wave would get pushed back another week, and then it get pushed back another week. And the units that we were floating to, like cross-training, they're like, what are you doing here? We don't need you. So I felt like I was wasting my time and taking up other people's time that were trying to get hours too. And this opportunity presented itself and I took it.
Do you think that the reason you never got a COVID wave in Florida was because of any of this lockdown? Or, I know you're not an epidemiologist,
No,
but what do you think was going on?
I live right by, and that was like worldwide news. People were at the beach. I was one of those people at the beach with my kids. Sunlight, it's vitamin D, it's good for your immunity. Fresh air, salt water, all these things are really good for anyone's, immune system. You have to be out. Mental health, we were all at the beach.
And so people, if there was a lot of transmission going on.
Wouldn't you think our hospitals would be flooded? They were not. I'm right at the beach. I'm right by the beach. Didn't happen.
Because the lockdowns happened after all that, and
it was spring break. The beaches were packed. There's people from all over the world. Tons of New Yorkers live by us.
I know I'm asking you to speculate here, because you really feel there is something, a new disease called COVID-19, do you feel that that's the case, or do you think that this is, I know there's a lot of mislabeling and I know all that, but there really is something new, right?
Yeah.
So, okay.
Yeah.
Okay. And why do you think it, places like New York got, we can see that what you were describing at Elmhurst was that they were packing people in together. And so that would cause spread. But why do you think a place like New York got hit so much harder than other places?
I thought about that already. What I found is that before this happened, because it didn't make sense to me. I'm sitting at home, I'm waiting for work, I'm stressing out. A lot of my friends are doing the same. So I'm digging. I'm why is New York, what is it, because there's that many people crunched in together? But ultimately what I found is that the hospitals here were already struggling. I think they shut down multiple hospitals because they couldn't afford to keep them open. So that made sense to me, even though I didn't want it to make sense. There's really no other rhyme or reason, because
but do you think we really do have many more cases, regardless of whether or not people went to the hospital?
I think they're forced cases. Sure, people are coming in with COVID, whatever that may be. It is something. But not everyone, but they're admitting these people. That's the difference between New York hospitals or these, Michigan, the states that were, hit the hardest, quote. They're admitting these patients as possible COVID, calling it COVID.
Or rule out COVID.
When they maybe just had a little congestion.
If there was something you would want to tell everyone in the country and everywhere else, what one last thing, what would it be?
I would say this is the one thing that I've had a struggle with, is if someone like me or anybody is trying to tell you something that might go against your beliefs, just listen, really just take it in, and instead of jumping on it, think on it for a night or a day and look into this stuff, and ask people about it. Not every nurse is going to have the same experience. A med surg nurse that's on the floor, even in my own hospital, has not had the same experience as the ICU nurses have. And once I sit down and explain it to them, it all makes sense. They're like, yeah, that makes sense. We see that because we'll send them to your, so just think about it, and be respectful, and we don't want to, no one wants to put themselves in a situation like this, and it's really hard. And this is the reason that a lot more people and nurses are afraid, because people are so quick to, defend something that they don't really understand.
What are you referring to in particular? This protocol, or what?
Like I referred to earlier, if you tell people something enough over and over, like the media was telling people, vents, 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 vents. And then you say, as a nurse, no vents, it's not a good, it's not a good position to be in, because I'm going against what the government says. But does the government really have everybody's best interest in mind? Are they thinking of, the 57-year-old grandma that, didn't have to die, or the 37-year-old that was totally fine when he walked into the emergency room and he didn't have to die? Are they thinking about, maybe the guy that had a drug problem that didn't have to be vented, but he saved his own life? I don't have anything to gain, I have everything to lose by sharing what I'm sharing right now, but so be it. I think it's important that these families get closure, and I hope that someday they'll be able to, hold them accountable for what they did.
A few days after we recorded this interview, Erryn began to feel that her time at Elmhurst was drawing to a close. Her vocal questioning of hospital procedure and her efforts to get the word out on social media were getting noticed. She made this recording on what ended up being her last day at the hospital.
I've been taking care of a patient for a week right now, and this is my and I called him. And he's been doing great. He had a trach put in, and he's been doing great. He's been talking and or communicating with me. He's telling me, laughing at my jokes, and talked to his kids on FaceTime a couple days ago. And I told his kids that he was doing fine. And he was. And today I was giving him, and they came in and they told me that I need to leave the room and I have to give report to somebody else. They took me from that unit and they put me in the emergency room, and they don't need me there, but they put me there, and I'm not even there 20 minutes. I'm not even there 20 minutes, and I hear a code being called in my room that I was just left. And it's him. And he was fine. He was fine. I don't understand. Nothing makes sense. Why would they take me out of his room and put me in the ED? And then not 20 minutes later, he's dead. It doesn't make sense. Did they kill him? He was my one patient that was gonna live. He shouldn't have died. I don't know what they did to him. Something's not right.